Today we're going to talk about management of insulin. Now you may be on insulin for various reasons, as discussed on a previous video. If you are a type 1 diabetic, insulin is really your only management option. But a lot of type 2 diabetics are also insulin requiring. So again, you could be insulin dependent or insulin requiring, but nonetheless, it's very important that you know how to manage insulin yourself. I really discourage you from counting on your physician to do this, because your physician does not live with you. So it's very important that you have a strategy for managing your insulin yourself so that you can get yourself under as good a control as possible. There are different strategies for insulin therapy. One of the most common ones these days is a combination of a basal insulin and an ultra short acting insulin. Examples of a basal insulin would be glargine or Dedimer, and then ultra short acting insulin such as Lispro, Aspart, or perhaps even regular insulin, although regular insulin has a little bit longer duration of action than the ultra short actings, but it could conceivably be used in the context of a basal insulin and a short acting insulin. The other combination would be NPH insulin, which is an intermediate acting insulin, along with regular insulin. That is one of the older regimens. It works just fine. The combination of a basal and short would be my preference. I think it gives you a little more flexibility, but NPH and regular can certainly be effective if you know how to make adjustments and manage it. And then a third category that we will discuss are various premix insulins that are available. The first regimen we're going to look at is a combination of a basal insulin along with a short or ultra short acting insulin. The thing you need to realize is insulins will tend to have a peak effect and then a duration of action. So with a short acting insulin, say if you take a shot of insulin at this point in time, it's going to kick in, it's going to have a peak activity pretty closely after administration, and then it's going to go away relatively quickly. That's as opposed to like an intermediate duration duration insulin. Even if you take it at the same time that you took the short-acting insulin, it's going to have a more gradual onset. It's going to have its peak activity later in the day and then go away more gradually. Now, the interesting thing about basal insulin is that it does not really have a peak. It has a plateau. So if you take a shot of a basal insulin, it's going to reach a plateau, and for all intents and purposes, it's going to last all day long. You can count on them having a duration of action for about 24 hours. There is no particular reason to take a basal insulin more than once a day, except in the situations where you're on a very high dose, because I have seen patients that are on extremely high dosages. You will stick the needle in, squirt the insulin in, pull the needle out, and half the insulin leaks right back out. So again, in my patients who are on very high doses of basal insulin, I will often split dose so that I give half of it in the morning, half of it in the evening. Really no reason to give a different dose in the morning as opposed to the evening. But again, if possible, I just dose it once a day. Doesn't matter whether you give it in the morning or the evening, but it is important that you stick with your regimen. So if you start taking it in the morning, you need to continue to take it in the morning, or same if you happen to take it in the evening. So the way you dose a basal insulin is because it doesn't have a peak, we're going to use our fasting blood sugar to determine the appropriate dose of a basal insulin. So just remember, breakfast is break fast. So your blood sugar before breakfast represents your fasting blood sugar. And so our goal is to get you on a dose of basal insulin that will maintain your fasting blood sugar between 120 and 140 initially. And again, this is when we're first starting out and getting comfortable of managing insulin on our own. As you get more comfortable with it, you may certainly want to tighten those blood sugars up even more. But again, initially we're going to use fasting blood sugar to determine what dose of basal insulin will maintain our blood sugar between 120 and 140. I'm able to be more aggressive in the hospital with how much I adjust these doses. But if you're doing this on your own, the one thing you want to be sure you do is avoid hypoglycemia. So be careful because you absolutely must avoid significant hypoglycemic episodes. So as far as what your starting dose should be, that is difficult to determine because there is really no formula that will tell you how much insulin a given person should be on, because it all depends on how sensitive you are to insulin. And so, of course, with type 2 diabetics tend to be insulin resistant, so they will tend to take more than a type 1 diabetic. But let's just say we start somebody out on 10 units, and again, it really doesn't matter when you take it, but we'll assume you're taking it in the morning, although a lot of people choose to take it in the evening. But again, really doesn't matter. But if you see that your fasting blood sugar is consistently out of our range, well, you need to be on more. So again, if managing insulin is new to you, you would maybe go from 10 units daily to 15 units daily. Try that for a couple of days. If that's not getting the job done, go to 20. If you're somebody who's very resistant to insulin, 5 units may not make a bit of difference. So you might be somebody who needs to make your adjustments 10 units at a time. Again, you really do have to figure this out for yourself. So again, that's how you're going to make adjustments to your basal insulin. It's going to be based on your fasting blood sugar. So basal insulin by itself is not going to give you adequate blood sugar control. So we often will use the basal insulin combined with a short-acting insulin. What I usually start people out with is what's called a sliding scale. With a sliding scale, you're going to check your blood sugar before breakfast, before lunch, before dinner, and at bedtime. And so then your physician would have given you a sliding scale to follow, and all you do is you look at your blood sugar, then you look at the sliding scale, and it's going to tell you how much correctional short-acting insulin to give yourself. And again, the intensity of that sliding scale is very much patient dependent. Again, depends on how sensitive you are to insulin. Here's the problem with a sliding scale. Let's pretend you wake up in the morning and your blood sugar is 120. Well, that's right where we want it. So you would not need any correctional insulin. But what happens after you eat breakfast? Your blood sugar is going to go up. And so let's say you check yourself before lunch and your blood sugar is 200. So you would look on your sliding scale and it would show how much correctional insulin to give yourself. And so presumably your blood sugar will come down, but it's lunchtime. So you eat lunch. What happens to your blood sugar? It's going to go right back up. And you're not going to know that until you check your blood sugar before dinner time. And let's say it's 225. So once again, you're going to take some correctional insulin. You're going to bring your blood sugar down, but you're going to eat dinner. So your blood sugar goes right back up, and we don't know that until you check your blood sugar before bedtime. You take correctional insulin, and presumably you maintain it at a reasonable level until the following morning, and we start this process all over again. So my point is, if you are just using a sliding scale, you're spending a majority of a day with your blood sugar running too high. So what can we do about that? Well, if you really got it going on and know how to carb count, you will be able to actually look at a plate of food, identify how many servings of carbohydrates you have on your plate. And at that point, you would just give yourself an appropriate amount of insulin to metabolize the amount of carbohydrate that you're fixing to consume. There are different formulas you can use to figure that out, but most people who know how to carb count, they can really just do it by sight. They just take a look at the plate of food and know that, okay, I need to take this much short-acting insulin. So that's great when you get to that point. But until you get to that point, what I usually recommend people do is just when you're getting ready to eat, just go ahead and take a set amount of short-acting insulin, because if you eat breakfast, you know your blood sugar is going to go up. So just go ahead and take some short-acting insulin in addition to whatever sliding scale you might need. And so what that will do is hopefully it will just put you down here so that your blood sugar's just running at a reasonable range all day long. But at the very least, instead of popping up to here, maybe it'll just pop up to there. So I usually tell people to start with 3 units of short-acting insulin with meals. So you're taking your scheduled basal insulin whenever you take it, and then with meals, you are first checking a preprandial blood sugar to determine how much correctional short-acting insulin you need, and then you can also add some prandial short-acting insulin. Just again, you're trying to prevent this markedly elevated blood sugar after your meal. We're trying to better control that. So again, I usually have people start with 3 units, and so do that for a few days. And if after doing that you see that you're continuing to have to take additional sliding scale correctional insulin, well, you're not on enough. So go from 3 units to 5 units. If that doesn't get the job done, go from 5 units to 7 units. If that's not getting it, go from 7 to 10. You just have to get comfortable playing around with these dosages so that you can get yourself under control. Now, understand that it's not like the short-acting insulin and the basal insulins act in isolation. They don't. They're going to affect each other. So what you may notice is that as you bring your postprandial blood sugars under better control, you may see that your fasting blood sugar starts coming down. So it may be necessary to make adjustments to your basal insulin, and not increasing, but actually decreasing the dose of the basal insulin. So again, you're paying attention to 2 different things. You continue to watch that fasting blood sugar so that you know what to do with your basal insulin. And then you're also using a sliding scale and making adjustments to a scheduled prandial dose of a short-acting insulin. And if you will do this, you can get your blood sugar under perfect control. But you have to work at it, and And you have to understand this strategy to be able to do that safely. And once again, I can't stress enough, be very careful while you're doing this. You want to absolutely avoid any significant hypoglycemic episodes. Hypoglycemia will kill you right now. And whereas blood sugars running up high over a long period of time are going to cause you a lot of problems down the road. But don't kill yourself now by taking too much insulin. So if you're on this type of regimen and say you know you're going to miss a meal, well, don't take the scheduled short-acting insulin. And do the sliding scale, but just don't take the scheduled short-acting insulin. And like if you're sick and know that well, you know, I'm going to have poor oral intake for several days for whatever reason, well, you might want to consider backing off a dose of your basal insulin. Maybe just take half a dose. But if you're sick, understand sometimes that can actually cause your blood sugar to go up regardless of whether you're eating or not. So you just have to pay attention. Very important. So again, if I were diabetic and had to be on insulin, this is likely what I would do. In a way, this is mimicking an insulin pump. Not a huge fan of insulin pumps, and so I'm not going to be talking about that just because, quite frankly, I don't know a whole lot about insulin pumps, but I've seen lots of bad things happen with them. So if I had to be on insulin, I would be on a combination of a basal insulin and an ultra short-acting insulin. So this works. You just have to know how to manage it, and again, it's very important that you manage it. Don't count on your doctor doing it. The next regimen we're going to look at is a combination of NPH insulin, which is an intermediate acting insulin, and regular insulin, which is a short acting insulin. The reality is sometimes your insurance or your finances will wind up dictating what insulins you were able to afford and use. And so the NPH and regular are some of the older insulins we have. In fact, it was all we had for a long time. It is just as effective as any other insulins. It's a little bit more trouble to manage, but as long as you understand the strategy, it's just as effective as any other insulin. So as we discussed on the basal and ultra short-acting insulins are going to have a peak onset and duration of action. So with regular insulin, you take a shot of it, its peak activity is going to happen relatively quickly, and then it's going to go away relatively quickly. That's as opposed to NPH insulin, which again is an intermediate acting insulin. Even if you take the NPH at the same time you take your regular insulin, it's going to have a more gradual onset of activity, and then it's going to go away more gradually. Now, when you're on NPH and regular, you really have to take it twice a day. It's not like basal insulin that's going to last, for all intents and purposes, 24 hours. It doesn't have those long duration of action. So generally, people that are on this are going to take a shot in the morning and then also at dinner. And so at dinner time, same thing. Your regular insulin's going to kick in relatively quickly and then go away relatively quickly. And the NPH is going to kick in more gradually and then go away more gradually. So you can see by taking NPH and regular twice a day, we have 4 peaks of activity. And you can also see that the peak activity of your morning AM regular is controlling your blood sugar before lunch. You can see that your morning NPH is controlling your blood sugar before dinner. Your evening regular is controlling your blood sugar before bedtime, and your evening NPH is controlling your blood sugar before breakfast the following day. So, understanding that, you can figure out what dosages of these various insulins you need to keep your blood sugar under control. And as with the other regimen we discussed, your goal, at least initially, is going to be for a blood sugar between 120 and 140. And once again, as you get more comfortable with this, you can tighten things up. But again, this is a good goal to start with. So, once again, the critical thing here is avoid hypoglycemia. So be very careful as you're making these adjustments, so that you don't suffer from any hypoglycemic episodes. So one of the advantages of being on NPH and regular is you can actually mix those insulins together. So you can figure out how much regular do I need to be taking, draw it up in your syringe, how much NPH do I need to be taking, draw that up in the same syringe. And so again, that allows you to just have one stick rather than two sticks. Now you cannot do that with other insulins, but you can mix NPH and regular. And in fact, the next regimen we're going to talk about is pre-mixed insulin, and that is exactly what that is. It's just pre-mixed in a set ratio. But again, in order to get really good blood sugar control, you really need to be mixing the NPH and regular yourself, because your body is rarely going to conform to the ratios in a pre-mixed insulin. But again, if you will learn this strategy, you can get your blood sugar under very good control with these old insulins. And again, one of the advantages is they're much more economical than other insulins. So the next thing we're going to talk about is pre-mixed insulins. Next, we're going to talk about pre-mixed insulins. If our bodies read our textbooks and conform to what they tell you, 70% of our insulin requirements would be given in the morning, and 30% would be given in the evening. And if you're on a regimen of NPH and regular, 70% of an insulin dose would need to be NPH, and 30% would be regular. So the number to remember is 70 and 30. So again, 70% of your total insulin requirements will be given in the morning, 30% would be given in the evening, of which 70% would be NPH and 30% would be regular. Now the reality is that our bodies do not read our textbooks, and so our insulin requirements rarely actually conform to this, but it is a good place to start. So if I have a new diabetic and we're going to use NPH and regular, that's basically what I will do. If they're a type 1 diabetic and their insulin requirements tend to be on the low side, I might start with, say, 10 units in the morning and 5 units in the evening, and adjust from there. So one of the interesting things about NPH and regular is that the NPH and regular can be mixed, as we discussed previously. And so it turns out that you can purchase pre-mixed vials of NPH and regular. Now, there are also set ratios of not only 70 and 30, but also 75-25, I've seen 50-50, and there may be some others as well. I also want to point out that 70-30 insulin is available in an ultra short acting insulin. Now, it doesn't actually have two different types of insulin in it, but it acts just like these premixed insulin. I'm not sure exactly how it's done, but somehow they got part of the ultra short acting insulin kind of tied up so that it's released more gradually. But with these premixes of insulin, again, going back to our previous discussion, you're going to have two peaks. So that if you take your premixed insulin, you're going to have a peak here, and you're going to have a peak there. And then you take your evening dose, and you're going to have a peak here, and you're going to have a peak there. So it looks just like the graphs would if you were mixing your own insulin, but again, this is already mixed for you. So the disadvantage to this is, as I've already mentioned, our bodies just don't read our textbooks, so this is not likely to really get you under good control as if you were mixing your own insulin. But again, for somebody who is not comfortable mixing their own insulin, this is a great place to start until you do get comfortable with managing your own insulin. Then you can go from the premixed insulins to mixing your own. But as far as making your adjustments go, now you're going to be limited because you have no way of adjusting just the regular or just the NPH. You have this premix ratio and you are stuck with that. So what that means is again, our goal is to get your blood sugar between 120 and 140 across the board. You are probably not going to be able to do that with a premixed insulin. So what you have to do is when you're making adjustments to your morning premixed insulin, you just have to pay attention to your preprandial, lunchtime, and dinner time blood sugar, and as soon as either one of those gets within our goal range of 120 to 140, you are done. If the other blood sugar is running higher than that, even if it's running much higher than that, you cannot continue to increase the dose of your premixed insulin because it's going to cause your other blood sugar to run too low. So again, for your morning premixed insulin, your goal is to get your lunchtime and your dinner time, either one of those within 120 to 140. As soon as either one of those reaches that goal, you can't continue to increase. Same thing with your dinner time premixed insulin. Your goal is to get either your bedtime or your morning time, the next morning, blood sugar between 120 and 140. But as soon as either one of those hits your goal, you're done, even if the other blood sugar continues to run high. Now you can do some correctional insulin with the other one to get it under better control, or as I have alluded to, better yet, start mixing your own insulin. And I think you'll have better control that way. Now the one thing that I do need to be sure that you're aware, when you're on an intermediate acting insulin that's giving you that peak later in the day, again, you've got this second peak that's happening because of the insulin that you took way back here in the morning is not really having an effect until later that evening. So so think of that as you have already taken insulin for a meal that you have not yet consumed. So you have to be very careful about skipping meals. And again, that's a disadvantage to premixed insulins and just using intermediate insulins in general, again, like NPH. So intermediate acting insulins, you have to be fairly regimented about when you eat. You simply can't skip meals. And so that's why my preference is not for the premixed insulins and the the NPH and regular insulins, but rather the basal insulins and ultra short-acting insulin, because then you're not as tied to meal times as you are otherwise. So again, any of these insulin regimens will work. It's just of the utmost importance that you understand how to manage these. You have to be able to manage them yourself. Do not count on your doctor. So good luck with this. It does work. You just have to pay attention.